opportunity to work in King Saud Medical City, one of the biggest hospitals in Riyadh. I spent a decade there. Then I moved on to Korea, South Korea, that is. Obviously, it doesn't need to be mentioned, South Korea, but in Seoul, where I was trained as a robotic surgeon, essentially. And now my current place of work, Londonderry, where I'm working as a consultant in upper gastrointestinal and general surgery. My principal interest is in the entire realm of the upper gastrointestinal surgery, but particularly in cancers, because my training has, it's always been, and my work has, much of it has been around cancers, so upper GI cancers, stomach and esophagus. Now, what is a lexicon of the early 21st century physician? It has much changed now. As you can see, these words were really unknown to us at the turn of the millennium. We were not aware of these, either on the left hand or on the right side. The precision medicine, artificial intelligence, machine learning, deep learning, artificial neural networks, data mining, metaverse, they were all totally unknown to us. And likewise on the left, on the right side, the precision surgery, the computer-assisted surgery, robotic surgery, which is my passion, autonomous robotic surgery, which is coming in the days ahead, and then the image guiding surgery, and something which is missing from the list, the telesurgery. So all of these were not in our lexicon, but now they are. And a surgeon in this present day and age cannot call himself an astute or an efficient surgeon if he is not aware of these concepts. So what is computer-assisted surgery? Computer-assisted surgery, by its name, explains itself. It's self-explanatory. It represents a concept. It's a philosophy. It's a set of methods. And what do we do is that we use computers for planning and guiding and performing surgical interventions. So no longer a surgeon is on himself or all alone. He is taking the help of the computer, that intricate device which can hold that, which can assimilate that, and it can give it a tangible shape. And that's where the surgeons are becoming wiser. So lots of names attached to it. And obviously, these all are manifestations of the same philosophy. We need to understand it's a philosophy. Just like computers is all about logic, it stems from philosophy as well, wisdom. So likewise, computer-assisted surgery is all about accumulating and assimilating the wisdom of images, of data into surgical practice. And it's also known as computer-aided surgery, computer-assisted intervention, image-guided surgery, digital surgery, and surgical navigation. All of these are similar concepts, all related. But then comes to my field of interest, where I am totally immersed in, robotic-assisted surgery or robotic surgery, which is a surgical procedure which is done using robotic systems. We need to understand it's entirely a different concept. It's all about mechanical here. Obviously, we're relying on the computers, that we take the advantage of the technology, but it's all about mechanics. And that's why it's either telemanipulator or a computer. Now, what's in a telemanipulator is basically a system like the Da Vinci, which I have been, trained on. That it's a system of remotely controlled manipulators. Remote. It's not that remote. It could be in a room. It could be in another room. It could be across the sea, even the telesurgery. But nevertheless, it has to have a manipulator. It has to have a master-slave relationship. There has to be a person on the controls. It's like driving a car, but a very sophisticated car, a very sophisticated flying machine. You can do any analogy, but it's basically a master-slave relationship. But it allows the surgeon to operate real-time under stereoscopic vision. The vision is the crux. The vision that you enjoy while doing this kind of a surgical maneuver is amazing. It's 3D, three-dimensional. It's immersive. It's as if everything is around you. It's like a panorama on your eyes. From a control console separate from the operating table. On the other hand, the concept of computer control systems, where the surgeon is using a computer to relay the control data and then direct the robotic arms. Now we have an interface here, and it's in effect and effective. So what it means is that you are doing the surgery, that you are still the master, but then there is an intermediary in between. So robotic assisted surgery can have two types or two shapes. Tele manipulator, tele means far, manipulation means some hand movement, some sort of a device movement, some mechanical translation, but still it has to have a direct relationship like the one that we have in Da Vinci. On the other hand, it has an interface of computers. Now, last of all, the image guided surgery, which is a discipline which has shaken the practice entirely. That now using computers, ultrasonic, electromagnetic dyes like the indocyanine green, the one which turns the field green on the relevant structures, the ducts, the arteries, the veins, the perfusion, and the viability and the lymph nodes, which has changed our appreciation of the surgical field. Basically, what you are doing is you are not looking at a plain white image, that you are looking on your screen or on your monitor. In fact, it's colored. It's colored to suit your practice, to suit your pathology, to suit your area of work, whether it's on the abdomen, in the chest, in the neck, or even on the breast. Because anywhere you can use these tools, and all these are computer generated, and they essentially enhance the practice, enhance the precision. So, so as you can see, it relays the patient's anatomy. It makes a surgeon's movement precise in relation to the patient, and it can be, augmented as well. How? By
Professor Lukman, we are not hearing you. Professor Lukman, we are not hearing you. I think Professor Lukman.
He's talking from UK. Maybe there's something wrong with the net there.
I think yes. I think she.
Sir, he got disconnected. His bandwidth is
No
low.
problem. Okay, no problem. We're waiting for.
It's a wonderful topic.
It's a wonderful topic. He is, I think, disconnected. Yesterday was the same problem, and somehow, even the somehow are unable, people were unable to share the link, and I offered my services. And yesterday I served as my laptop for their presentation.
What was the topic yesterday, sir?
Prevention of the cardiac diseases.
Let's have a few webinars on monkeypox.
Yes,
then.
very
Hello?
beautiful topic. Okay, Lukman, no doubt. It was we are waiting for you. Okay, Dr. Professor Lukman.
Yes,
Yes. Start again, sir. No problem.
no problem. I'm with you, sir. I'm with you.
We lost you some minutes back. Can you please continue?
Yes.
Dr. Lukman, there's something wrong with connection from your side.
Thank you.
Yeah, I think there is one, and I'm trying to fix it.
Okay. Yesterday,
It's fixed
there are
now.
four. Can I give few?
Can we now? I think we are back now. I think we will stay now very safe now. So I think can
You
we
are
resume?
starting again?
Can we resume?
Yeah,
Yes,
please do.
Yeah, you start from where you stop.
So I don't know where I stopped. Was I on this slide?
Yes,
Was this the slide? Can you see the slide, sir, now?
No,
can you share
not-
your slides?
Just hold on. I will share where.
Dr. Lukman, this is the background in London. Your actual background in your home? Okay. Dr. Salman, Dr. Lukman is my student in Bahawalpur, Qaeda Medical College. He was
Yeah,
very
absolutely.
intelligent, excellent student, and a topper
Mashallah.
students. He
So
was the
now,
topper.
so now, can you see me now? Can you see me now?
Yes,
I
yes,
hope
we are
you
looking
can
at.
see me now.
But we are not looking the slides.
Yeah, what I will do is now, I think somebody has to, yes, I will share my screen now.
Yes.
I'll share my screen. I hope you are sharing now.
Yes, your
Yeah,
whole screen is open now.
Yes. But I think we need to be a little bit patient because now we are back. I hope we are back now.
We are here. I think,
Yeah, yeah.
yes, we are.
I think I just moved. I didn't know that we had stopped. Yeah, no, it's okay.
Covered this topic. We covered
Yeah,
this
we covered
slide.
no,
this
And,
one.
we've covered the slides. Yeah,
we
now
also
that's
covered
it.
this. Yeah, we are here.
We were here basically.
Yes, we are here.
So,
here.
yeah. So now, as you can see, that the image guided surgery is basically a further concept. So all are coming together using the computer as an interface. Now, what is artificial intelligence? Yes.
Yes.
Yes. Now, artificial intelligence is intelligence, and what it does is basically that it's all about perceiving, synthesizing, and inferring information, which is demonstrated by machines, as opposed to intelligence displayed by non-human animals or by humans. So, artificial intelligence is all that we are collecting the data on the computer, and we are trying to synthesize it into something meaningful. And now, on top of it, within it, is a concept of, it's like an onion. So as you will peel the onion, the outer layer is a artificial intelligence. And the first peel that you will see within the artificial intelligence will be machine learning. And what is machine learning? It's all about building and understanding methods that how the machines learn. That is something very amazing, that we are trying to give the machines the autonomy that where they can make a decision independent of a supervisory control by the human. And that is very fascinating. So within the field, the global, the definition of artificial intelligence, we have the second field, which is the machine learning. And within the machine learning, we have the deep learning. And the deep learning is basically about using artificial neural networks. And artificial neural networks is all about representational learning, and which can again be supervised, semi-supervised, and unsupervised. Basically, it's all about how computers make decisions and how these decisions are incorporated into a phenomena where the computers are taking decisions based on the perception, appreciation, assimilation of the data, and how can they aid in our improvement of our performance and of the output of the physician. But at the center of it, at the heart of it, is the artificial neural networks, without which all this edifice cannot stand. Either the deep learning or the machine learning or the artificial intelligence. It's the artificial neural networks. These are the basis how a computer or a data house or a data bank or a big data analyzes information, and it's on the basis of artificial neural networks, and it very much works like the brain. It will see an image, it will simulate an image, and then give you the information based on the appreciation. And the other name for the artificial neural network is the convoluted artificial network. It's not moving. Yes. Now can you see now? Now we can see. Now this is what I wanted to tell you today. The three are distinct but complementary. We just need to understand that artificial intelligence, robotic surgery, and computer surgery, these are interrelated subjects or related, but yet distinct and complementary. They are not alone. So artificial intelligence complements the robotic surgery complements the computer assisted surgery, and we go back together to the same point. Now you will see a short video so that you just try to see how things are. I hope it works.
Yes. Yes, yes. No, you here, you're here. Okay.
Let's see this video.
Can you
Very
enlarge it?
fascinating video.
Can you, Dr. Lukman, enlarge it? Okay. On left side, you go down and put here on the YouTube, and you can enlarge. Yes, here. Yes, you click here. Yes.
Oh, I think let's continue with this.
No problem.
I think let's continue with this. I think this will be better for us.
But there is no voice.
This is my practice basically. So you can see now how the robot is doing bringing a revolution. Now these are the various kind of platforms, and I have worked on nearly about 3 of them, which is the SP, which is on the right lower, the XI, which is the very popular, which was launched in 2014, and this has been the commonest, the one which is very commonly available all over the world in all the major centers. And as you can see, a robotic system has got 3 parts. One is a console. The console is on the right side where the surgeon sits. This is basically the stack or the laparoscopic or the robotic tower. which has a monitor, which is a touch screen, and it has all the components of the robotic system, like the insufflator or the coagulators or the energy devices, all placed. And this is the essential boom. This is called the boom. This is the boom which is centered on the patient, and these are the arms, the forearms. So as you can see, that this is a huge improvement on the previous versions. It is the one which is being utilized by all the surgeons, most of the surgeons in the world. And the new one, the new on the block is the single port. If you can see on the right lower one, which is a single port, means that you enter through a single opening, and then using the forearms, you can do a manipulation of the organ or the tissue. Essentially, robot is doing the job of the surgeon like a master slave, but it has lots of benefits, which we'll discuss later. The first one to come was the SI, which is this one, which is quite different. If you can notice, it's different. Its arms are separate. It does not come from a central boom. It does not come from the overhead. It's coming from the sides, but the console looks nearly the same. And this is an improved version of the S, which has been launched for the SCS. Now, what are the other competitors? These are the other competitors which are coming up. One thing which is very interesting, because one of the arguments against the robotic surgery was that it was expensive. But since there has been a collapse of the patents recently, or the expiry of the patents, so lots of other companies, high-tech companies, are venturing into it. And one robot which I have had the opportunity of using is the Revo Eye, the Korean robot, which is on the left lower. They all look nearly the same, except that the concepts are a little bit different. This is basically called a closed console, where you put your head in. This is called an open console, where your head is out and you're looking away. So you can see these two, or in fact, all these three, they are open consoles, where you are sitting away on a chair, but you're away from the patient. But this is how it is, you're away. It's called an open console. And this is called a closed console, where you put your head inside. But here you have to use 3D goggles to get the same effect. These are all 3D monitors. These are 3D monitors when you will look at, and you get a 3D vision. Here, the advantage is on these ones that the arms are a bit separate. They're just like assistance arms. So you can put one arm here and one arm there, and that's how it is. So you can just try to remember these names of Senhance, the CMR Versius, which is a British one, the Revo Eye, which is a Korean, and Hugo, which is a Medtronic. So now we have 5 players. From Da Vinci Intuitive Surgical, we are having a competition from Senhance, the CMR, the Revo Eye, and the Hugo. Now, what is happening? Now, what is happening is that how all this gets collated together is that about the data collection. That how do you collect all this data to make your robotic surgery safer, or your understanding of the pathology safer. So you can see that how many types of data that you can collect. It can be about the surgeon, environment, the sensors, the drugs, the preoperative, or the video recordings of the surgery, or the measurements. And this all is being collected. Now, this is very, very important, that you have to have a supercomputer, or sort of a supercomputer, which collects, assimilates all this data into a tangible science. Because until and unless it becomes tangible for the surgeon, it cannot be of any use. So now, when I was used to operate, and even now when we are operating, that we take measurements of the vessels, we no longer are abstract or arbitrary. We take measurements of the diameters, of the distances of the organ, of the lesion from a certain important vital structure, like from a right hepatic artery, left hepatic artery, or for that matter, the celiac axis, the SMA, all the major vessels, the middle colic, or the or the right colic artery, all of these are no more an abstract concept. Whatever we are doing is we are doing on measurements. These measurements are taken, recorded, assimilated, and then the surgeon, when he is doing a next surgery, he takes the benefit of it. So you can understand that how the data is being put to good use for our understanding and for the benefit of the patient. This whole exercise is to make the surgical exercise predictable, to make the surgery safer and the outcomes clearer. So now you can see that how can a automated surgical performance report can be generated using artificial intelligence. So we have taken the example of a robotic prostatectomy, which was one of the earliest procedures done. In fact, I was introduced to robotic surgery first through my urology colleagues. So urology started using, because pelvis is a narrow organ, there the robot gives you an unprecedented access to deeper structures, and there the robot has the advantage, the biggest advantage of having the 7 degrees of freedom, ability to have a wrist motion. The wrist motion is the one which gives you a superiority over the laparoscopic, which is just a 2 or 3 degree of motion as compared to the robotic, which is 7 degrees of motion. Just try to understand these few terms, and you will be able to enjoy the beauty of robotic surgery, that your hand moves like a wrist when you're using the robot, as compared to laparoscopic, where it's like a stick going in and out and rotating. So what you do is you do a endoscopic video data. The procedure is segmented. That is very, very important. Now every procedure is segmented, made into smaller components, and then the robot analyzes its dynamics and the events, and then there is a task-wise performance, and the metrics are evaluated, and a performance report is generated. Can you imagine? This was not possible before. It's all is not possible before, because we have stronger computers, we have a better understanding of data mining and of data management, and that's how all of this being collected into giving the surgeon an advantage of having a predictable surgery, a predictable outcome, or even to have a predictable success, that you will do some procedure and you will be sure that your procedure will be certainly successful and will not meet any failure. Now, we will again reinforce on the concepts that how all of this is being translated. You can see that if the surgeon sees an endoscopic image, just concentrate on the left side, he will see an endoscopic image. Now the artificial intelligence will detect a lesion, then it will classify that lesion. At the same time, using deeper modes of endoscopy, which is itself is also getting very intelligent now, you will be able to see, what is the nature of the lesion without even touching it. And if you take the pathology from it and relate it with the radiology, you will have a kind of a global understanding, which will be real-time understanding. It's not happening that I will be withdrawing my scope or withdrawing my robot or withdrawing my endoscope. In fact, it will be happening in real time. That is the advantage, that whatever you do, everything becomes predictable. You see a lesion, you detect a lesion, classify a lesion. When I was in Korea, you would be surprised that, all our endoscopic images, we could decide on the basis of just looking at a lesion, a flat or an elevated or depressed lesion. We could decide whether this lesion is benign or malignant without even taking a biopsy, because of the narrow band imaging. Narrow band imaging and data mining on the basis of narrow band imaging, that is not using the white light but the gray light, you can see so many much architectural details that it becomes very certain that what are you looking at. And when you have the help of the computer, your doubts are removed, because it has all the background other cases where they have seen similar lesions, and then it matches those images and it tells you for sure that this is benign and this is malignant. and you can take it on the table, real-time good decision, rather than putting it off or delaying it or getting into confusion. So last of all, the robotic and the laparoscopic recordings, they are the best tools of learning. Record the procedures that you do, and you revise them and read them and analyze them, segment them, and then you will realize that how you relate, how did you perform in relation to this particular lesion or that particular lesion, and how was your outcome. So all of this data does not get lost. It's stored, it's simulated, and it's brought to the benefit for the patient. Now you can just see that how the artificial neural network is doing image analysis. It sees a lesion, it starts classifying it. So it's not only you are classifying it. In fact, it is the computer is also classifying it just by looking at the image, because there's a data of images inside, and those images then using artificial neural network and deep learning, the computer will be able to tell you that your impression is correct, because I might say also this is malignant, but the computer will say, yes, you're right, that this is basically malignant. But on top of that, you in very early lesions, the delimitation, the boundaries of the lesion are becoming even clearer. So when you see a lesion, I will not be able sometimes to look at the subtlety of the borders. But when I have the advantage of a data bank or artificial intelligence, it will tell me this is the limit. This is where you stop cutting. This is where you stop cutting. Don't cut more. Don't go deeper more. So that is the advantage that we are taking out of artificial intelligence, and it has made our surgery predictable and safer. Now, if you can see that this is how, again, you can have another view of how things are, that if you are looking the role of the artificial intelligence, it can be at the preoperative level, intraoperative, and postoperative. Preoperative, it leads to better surgical preparation. It prepares for you for a personalized surgical planning. The precision surgery, if you remember, we talked about precision surgery. This is precision surgery, a personalized surgical planning. You know, when I was in Korea, we used to always be at the start of the procedure, I will sit with my team, we will see the images, we will see all the structures, vital structures in relation to the lesion that we will be resecting, all the lymph node stations, all the passing by arteries and veins, and we will be sure that once we will go inside, we will not have anything out of the blue. It's basically trying to omit the element of surprise from your practice. The more certain you are, the more precision your target will be clear, and your surgery will be executed with perfection. So you can do a 3D anatomy mapping, you can do pneumoperitoneum modeling, port placement planning, because we know that the port placements in robotic surgery or the laparoscopic surgery is of vital importance. And because that allows you the ergonomics. The ergonomics is that I put my ports and my hands are smooth, I target the lesion correctly, and there is no the trouble with my hand movements and my control of instruments. Intraoperatively, it's a real-time surgical assist. It gives you a navigational tool. You can do a synchronized camera movement. You can do virtual reality, like superimposing an arterial map or a lymphatic map on a pathology. You can superimpose those maps, and you can see that when you're looking at an image on the computer, on your screen, you just, with the touch of the button, you can see all the important anatomical and vascular structures. Now on the video hub, you can do recordings, 4K recordings, 3D recordings, and then obviously you can do an artificial intelligence empowered image recognition. And post-op. And post-operatively, you can analyze your work, you can do a data analysis, you can manage the events, recognition, detections, annotations, all of these things are possible now, all because of the facility of the artificial intelligence. Now, this was a very interesting slide, and I just used it because to tell you that obviously we adulate, we appreciate when we are doing systematic reviews the English language data. But obviously, sometimes we need to read about the other languages as well, and Germans and the Italians, they have done a lot of work on robotic. So if you see on the left lower side, it's nothing but about the advantages and disadvantages of robotic surgery. It is telling you about that the advantages are about high resolution, three-dimensional visuals, and the ability to zoom, the camera work, the high mobility with 7 degrees of freedom. I've told you about that you are able to work like a wrist inside the human body, and it filters out your tremors. So the tremors which come with age or with anxiety, they're filtered out because of the interface of the robot. And then obviously it is ergonomic. You're working away from the console, so you don't have to directly handle the abdominal wall or the any structure. You're sitting away from the surgical site, comfortable on your chair, and you're doing your surgery. So there is less fatigue, less back pain, and there's obviously a much easier learning curve. Just try to understand the learning curve of robotic surgery is far easier and far easier as compared to laparoscopic. It might be sounding strange, but that is the truth. Laparoscopic surgery is very entertaining, and obviously I will say entertaining because I'm a surgeon, but otherwise when you work on the robotic platform, you realize that robotic is far easier. But obviously, what are the negative points? It has the loss of touch, because obviously when you're using straight sticks, you tend to develop some sort of haptic feedback. It is totally absent of, obviously we are trying to improve on that, but it's still the haptic feedback or the touch is a bit weaker. And then obviously it requires familiarization. And then obviously the problem is the cost. The cost is what that we are trying to fight. And obviously, as I told you now, that there are new kids on the block, like the Sanhans, the Hugo, the Revo. They are certainly going to bring down the market, they're going to cool the market and bring the prices down because of the open competition, which is now everybody is foreseeing. So hopefully in the coming years, the robots will be more commonly available, and we will be seeing more robotic surgeries. Now on the right side, it's all about the level of evidence that we have for various kinds of surgeries. Now we need to understand that as far as the upper gastrointestinal surgery is concerned, we have now achieved that level where we say that the evidence is 1B. 1B is the best evidence possible. That obviously we have now randomized controlled trials, we have systematic reviews which prove beyond doubt that the esophagogastric surgery is very safe with the robot, and obviously we rely on that. Similar is the colorectal. If you look down at the bottom, if you see it is esophago resection, gastrectomy. On the last is rectum resection and hemicolectomy. Again, we have 1B. So in upper GI and lower GI surgery, lower GI is colon, upper GI esophagus and stomach, we have 1B evidence. Now, as far as liver and pancreas is concerned, more work needs to be done. And obviously, a lot of people are working on it. But obviously, as we can see now, that we have reached a place where it's now proven beyond doubt that if it is not superior, then it's not inferior as well. There's a concept when you're doing a research, surgical research, of non-inferiority. So we have proven that robotic surgery, if it is not superior, then at least it's not non-inferior as well. So that's how it is. Now, coming to the crux, whether the robotic surgery is better than laparoscopic surgery, in my view, robotic surgery is the best. I love it. But and those who are working in high BMIs, they will certainly support my word that in obesity, when the patient is heavy with a heavy abdominal wall and a big presence on the table, the surgeon presence around the table becomes a bit difficult, and there the robotic surgery becomes far easier. In fact, the studies are there where the turnover of surgical turnover, which we means is the number of procedures that you do in a day, become more using a robotic platform. So this robotic surgery may be expensive at the beginning, but the difference between laparoscopic and robotic peters out when you think about when you calculate the surgical turnover and the number of procedures are being done, so you can do more surgical procedures with the robotic after a certain period of time, achieving a certain learning curve. And studies have proven, where, particularly in bariatric surgery, the cost benefit analysis becomes even. Now we will see, I wanted to share with you some information about the robotic surgery that in the last, and this is basically a recent review of the systematic review, is basically a scientometric study, is a review of the reviews basically. So it tells you that how the research field has moved, because obviously that will tell you that how the research has generated, the interest has been generated into the research, and once you have the data, you can convince the audience about the feasibility, the viability, and the applicability of the robotic surgery, not only in the first world, but in anywhere in any corner of the earth where a robot can be taken, surgery can be conducted, and good results can be delivered. So you can see that in the America remains the country where the original publications are coming, and look at South Korea. Now that is very, very important. Just look at it. America, South Korea, Italy, and Germany. And see the others ones. These are the ones which have fallen, which are at the back. So the America and the South Korea, they are the generator of the original research. Now that's very, very important to understand, that America remains at the forefront, because we know that the most of the robots are in America, because America has over 5,000 robots. If there are 6,000 robots in the world, 5,000 are in America. The thousands are, the rest of the 1,000 are distributed all over the world, rest of the world. So if you look at the systematic reviews and meta-analysis, they are again coming from America and Italy, but look at China. China is not the generator of original research, but the assimilator of the original research. You can see how much interest that the China is taking in trying to understand the whole science. It does not show more than that. They may not be generators of original research, conductors of trials and conductors of original research, but they are trying to catch up with the rest of the world by doing systematic reviews and meta-analysis. They are trying to reach at the same spot where they can be the equal partners at an even level with America. And look at the Korea, which is at the top of the original articles, is at the bottom of the systematic. Probably they don't need it because they are the generators of original research. Likewise, look at the institutions. All of these institutions, if you look around, look at my institution where I was trained, Yonsei University. You can see this is one of the places where the original articles has been coming out the most on the field of research. And if you see on the other side that you can see, then Italy is at the top, and then obviously we understand that because Italy has a huge data centers, and likewise, so we can see the constellation of American institutions. But this is how it is at my institution where I was trained, the Severance Hospital, and that's where it was. And you can see how the authors are. Now you can see at the last, I will tell you that the fields where the robotic surgery has made its mark. It's in the field of urology, upper gastrointestinal surgery, colorectal surgery, gynecology, and these are the principal ones. Likewise, if you see on the systematic reviews, again, urology, colorectal, and upper gastrointestinal surgery, they stand out. Obviously, the effort is being made at the level of the veterinary to make, because obviously, if you don't have the evidence, you can't push your decision makers to put the money in. So the people are doing hard work on that. But in urology and colorectal and upper gastrointestinal surgery, the robotic surgery has come to stay, and it will play a definite role in these three areas along with gynecology and obstetrics. So in conclusion, the future belongs to artificial intelligence and robotics. All are related. They are not, they are separate yet inseparable. They are separate yet inseparable. So artificial intelligence, computer-assisted surgery, and robotic surgery, they are complementary, separate, but inseparable. And here I end my presentation.
Thank you so much, Professor Lukman. Really, it is a very nice presentation. Before I start and open the question and answer, can I ask few comments about your lectures? The one is that you said in the lecture that laparoscopy, if you compare it, the robotic is better than the laparoscopic. In what way you are expecting? Because still in Pakistan, we are away from the laparoscopy, and you are introducing
Basically,
a
sir,
technique.
sir, I think, sir, sir, there's, I will give you I'll give you a very tangible answer. There is a very nice book on head and neck surgery, and I will take you there. It's known as Maran and Stell. And I read the forewords. I'm usually obsessed about the forewords of the books because they're written usually by very eminent people. So, it said very nice that, specialization and super specialization is a corollary of economics. The economics brings forth the specialization and super specialization. The tragedy of Pakistan is that we are 225, 250 million people, but we lag behind in all the economic parameters. We have not done well in economics, and that's why we are not able to devote our budgets to these all technologies. Why Korea is ahead of the world, at the forefront of the world, is because a nation is rising and rising together. So you see that they are having a GDP which is one of the best in the world. They are having foreign reserves with the best in the world. They are having a sovereign wealth fund best in the world. So they have surplus money. So where they utilize that money? On technology, understandable. So in Pakistan, we are lagging behind in laparoscopic even, which is a tragedy because of the mindset as well as the lack of resources. And obviously, with all apologies, please forgive me, but we need to learn from our neighbors also. Our next door neighbors, they are doing absolutely wonderful in the field of laparoscopic and robotic. But
yes, even
that's how it
you
is.
went last month. There's so many artificial intelligence surgery centers there. Yes, you are right.
Yeah,
you are right.
So because we have to understand economics, and I still remember Maran's words that this is a beauty or the blessing or the outcome of a good economics that you tend to enjoy, or a luxury of a good economics that you super specialize or specialize. And obviously,
Yes,
we are standing still at the gates of all of these technologies because we don't have the economics. And
yes.
then the
Even
mindset. We need to
Dr.
think about the
Lukman,
mindset as well, sir. The mindset is also an issue, which I will not go into because that's totally a different subject altogether. The mindset, the inertia, I will not touch on that. But obviously, but I will say, a nation rises and rises together.
yes, because yes, you're right. No, it is the right time for us that we should include our information technology teaching, artificial intelligence teaching to our students, because in next 10 years, if anyone from us do not know how to use the artificial, even GPT, fourth model is now there, and we are unable to. Another objection on the robotic surgery and artificial intelligence is that if there will be next 10 years, there will be so many use of this artificial intelligence. How the surgeon will do, how the other paramedical staff, where will they go, and they are very effective.
I think that this has also been studied. There was a very nice, because obviously the topic is so vast and deep. There has been research done on this as well. In fact, when I was doing my, because obviously whenever you start your presentations or whenever you're doing a talk, you have to do some sort of a background research work. So I was just going through the articles, in the last 2 days, I saw a lot of articles on this issue because redundancy of worker redundancy. I think that the term that we use is redundancy, that the workforce becomes redundant when you bring in the robot. But the issue is that they are still, I think the West has coped very well with this, because there was a very fine article on this issue, that where they were advocating that the robot is an ally, not an adversary in the operating room. And the people who used to just spend their time handing over and collecting the instruments, they can devote their energies to handling the robot now, because somebody has to handle the robot. So they go on to a higher order of learning, because the nurses which will be doing the robotic handling, the robot handling, or the console handling, or the boom handling, they have to be trained. They can, when I was in Korea, we used to receive all these people from Japan and Malaysia, because Malaysia and Japan are booming economies, and they were the major buyers of technology. So what they would do is that they would be coming a surgeon and a nurse, a surgeon and a nurse. So I would ask them that, who are you? They would say that I am a surgeon and she is a nurse. And why we have brought the nurse? Because one nurse has to understand the workings of the robot, so that she should be able to dock the robot, undock the robot, couple the arms to the ports, and so on and so forth. So obviously, I think there is a question of redundancy, but I think that can be tackled.
Dr. Nabia Tariq, Professor Nabia Tariq is Professor of Gynae. She has asked the question. Professor Nabia, you can ask directly.
Yes, please.
Dr. Nabia Tariq, Professor of Gynecology. Professor, she has a question that do share some link. Who can?
I think that I can be contacted. I will be surely most happy to guide, because this is what I feel, that this is my duty right now at this stage of the career, to guide my juniors and to tell them what is the right way to see and to move forward. Because otherwise, this is how it is. We have to pass the baton to the younger people, to the younger generation. We have to encourage them. We have to build our workforce in the best manner possible. We have to incorporate all the technology, and the best way is to encourage our younger lot. They are our hope, because they will start working at a much younger age on these technologies, as compared to me, or as compared to my other peers who took all of this at a much later age. They are kids, and sooner that you start. And I will tell you an example. There is a very fine surgeon, and I saw him speaking. His name is Daniel Hashimoto. He's a Japanese American. He was a resident when I heard him talk about artificial intelligence in one of the conferences. And I was so fascinated by him, that he is a young man. And would you believe now that once he has done his fellowship, that he has become a surgeon? The Harvard University and the Yale University have set up a center for his work, for doing artificial intelligence, to do the data mining, to do all of this, data collation, assimilation, because that's what it is. You can't expect a person, you need young people to come into the field and take the initiative, and the senior has to guide, and we are there for them. They can contact me at any time. My address is there, and I will be most glad to. I will share my email, and please contact me at any time. I will be most glad to. I will give you my official email as well.
But nice of you, Professor Luqman.
And I will love that my juniors should. Yeah.
Dr. Luqman, we also invite you in the Jammu Kashmir Medical College to come and to our residents and our students.
Absolutely,
Especially
sir. I will be at your service, sir. I will be at your service.
Professor Salma Kundi, you have raised the question, madam. Over to you.
Haji, it was a lovely talk by Professor Luqman. I was only wondering, Dr. Luqman, you are in UK. So by any stroke of luck, if you get this robotic technology in Pakistan, can you operate on a patient while sitting in UK?
Absolutely, it's possible now. Professor Kundi, this is the Lindbergh. There was a, there was a guy who took there was a gentleman, American gentleman, Carl Lindbergh, who flew from the Atlantic, across the Atlantic. The first man to do a solo flight across the Atlantic. His name is Carl Lindbergh. So this was known as the Lindbergh project, where a surgeon sitting in America operated on a patient in Europe and vice versa. So it is possible now with the technology of, this is called telesurgery, where the surgeon, obviously it has to be done under a certain framework, but obviously NASA is working on it because surgeons and because the astronauts will be going into space, and they will be, they may have some surgical malady or some other. So, and in fact, Professor Kundi, the idea of surgical robot came from NASA. It came from NASA Aeronautical.
How fascinating.
Yeah, it came from NASA. The idea of robot came from NASA, and the word robot was the invention of a Czech playwright who thought about, robot is not an English word, it's a Czech word. If you know, there's a country called Czech in the heart of the Europe. The capital is Prague, and my favorite author he's a very sad author, but I like his work. His name is Franz Kafka. I hope if you have read Kafka, you will know Czechoslovakia, Czech. So there's in fact, this gentleman, I'm not talking about Kafka, but another gentleman, he was a Czech playwright, and he invented the word robot, where a artificial person or a being is doing human activity, and that he called robot. And that's where we have taken robot. And Lindbergh project is the same concept. Across the Atlantic, you sit in America, do the surgery in Europe, and vice versa, sit in Europe and do in America. And it's all possible.
Any other question? Any other question? Okay, I am afraid that after some time, there will be robotic.
This is a very nice question. That's very good. That's very good question. Dr. Mahdi is asking a very good question, and I'm very grateful for this question. I would like to answer it. Mahdi, if there's any on-table problem, you don't need to convert now. I have a 0 conversion rate. Would you know that? You remember one thing? Mahdi, I would like to tell you, what you start. What you start open, what you start laparoscopic and laparoscopic, what you start robotic and robotic. So please do not have that kind of a, look, remember, you have to burn your boats. You have to be like Tariq. You have to burn your boats. Once you burn your boats, you will see that your learning curve will start improving, and you will become better. And I don't know which bleeder you are thinking about right now, in the context of which bleeder. Usually the bleeders are now very easily manageable, considering the surgical energy sources that we are available, whether it's a ligashore, or whether it's a harmonic, or whether it's the clips or the hemolocks, or the staplers. So just add another port, and you can you can go from the console to the laparoscopic also. Obviously, you can undock the port, hold it at your one hand with your grasper, go and start doing your work. And would you believe, in my time, in my work, as yet there's no conversion. So obviously, if things are bad, so what can you do? But I obviously, there is never a never, and there's never always and always. These are very bad words, but you have to keep, you have to think like Tariq. You have to think like Tariq. You have to burn your boats. Once you burn your boats, you're grounded. Then you look for a solution, and you will be able to do it. And just add a port, or change your from the robotic to the laparoscopic, and you will be able to stitch and sew, or staple, or clip, or use surgical energy. But obviously, you need to have all these ancillaries and devices at hand. You need to have trained personnel. You have to have institutional support. You have to have a certain mindset. All of this has to be. It takes a lot of grounding to take the weight on your feet. You have to hold yourself, and obviously that's hold your nerves, and the results can be phenomenal.
Dr. Mubashir, you can ask the question, Dr. Mubashir.
Yeah, please do. Please do. I'm most interested to answer.
Be unmute.
Yeah, thank you, sir. Yeah, thank you, sir. I actually wanted to highlight a few things. I was very nice talk. And certainly this is need of an hour that we should learn about AI and how we can use it in medical sciences to improve our learning and teaching and further providing help to patients. But like I was thinking that when we are neighbor to China, and China basically is the leading force in AI in the world now.
Very true.
In 2016, in conferences, when we listened to the Chinese presenting AI concepts, they were like only one or two. But by next 3 years, by 2019, there were only foreigners available in Chinese AI conferences.
Amazing.
So now the Chinese conferences AI are run by all Chinese,
Very
and
nice.
a lot of the best autonomous car in the
Very
world
good.
is run by Baidu in
Very
China.
nice. Very
And
nice.
China in robotic surgery is absolutely advancing, and they are basically leading the world as well in terms of research in robotics and AI.
No, I beg to differ
So
with
I
you.
would suggest
No, I beg
medical
to differ with
colleges,
no, no, they're
institutions,
catching up.
professors, doctors,
Mubashir,
they should
I
like
think
find out,
no,
go and
no,
discuss with
Mubashir.
Chinese how they
No, I
can
will
build
intervene. This is my
collaboration.
subject.
They are
Mubashir, this
our
is my
very
subject.
close
Can I?
neighbor, and this can help. The telepresence surgery is 30 years old concept. It was practiced 30 years ago, not today. So this robotic surgery, assisted surgery, robotic assisted surgery, or all the different concepts are not new. These are very old. What to talk of, when you have a patient, you want to do a robotic surgery, you can basically augment it, simulate it, and know the result in advance before going in. We are here. Like when you have a procedure, you can basically get to know what are the possibilities and what will be the outcome. So the robotic surgery has reached to this level even that we can simulate a surgical procedure in advance. And the wealth component, where we talked of like whether the doctors will be out of job and robots will take over, it's not the, in 1890, when the looms were created in London and Europe, the people went and they started stoning those installations of those looms and mills, that probably they are going to take away the job. But you see the wealth cake grew. And similarly, this AI and robotics and machine is going to grow the wealth. Only issue is the wealth has basically consolidated in the hands of few because of the slavery, which is like a different type of slavery, which countries like Pakistan are basically slaved by others over the time, and our 3Js are slaving us as well. So I think people has to think out of the box, try to work on their own, try to build new initiatives, even small ones. Sialkot is a big thing. I always feel Sialkot can do a wonderful job by adding some new technology, haptics, or even simple risk creation into these machines. Amazing thing. Thank you, sir. Thank you. These are
Thank you,
the
sir.
things
Thank
I
you.
want.
Dr. Lokman, would you like to give your answer of these comments?
Yeah, I think I'm really enlightened by the comments of Mr. Mubashir, Dr. Mubashir. And
Dr. Mubashir.
I hope with a surgical background, because he was speaking so well on the surgical topic. But you know, the leader, the real leader of this, because obviously the youngsters are sitting, they have to understand that the
Yes,
real leader,
these are the youngsters. They're actually the future leader. Yes.
yeah, the future leaders.
We have to
So I
train
think
them.
we need to tell them that, you know, that as Dr. Mubashir is saying, that China is there as well, but we cannot overlook and negate the presence of Korea and Japan. And obviously, you know, that gives you a better understanding that, you know, that we should not only look towards the West, we can look towards the East as well, and the Far East as well, and we can take advantage of their prowess and their improvements, and we can assimilate them into our practice. So likewise, like I went to Korea because I knew that the Korea is at the forefront of the robotics. That's where I have to be. And so that's so on and so forth. And just to put the record straight, Korea is number one. Let's not be in a doubt about it. I think let's not have let's not have doubt about it. Korea is number one. Number two is Japan. Number three is China. So,
Thank you so
the
much.
reason is because somebody might take a different concept out of this, out of all of this, because I am in this field, I'm a part of this field. So number one is Korea, because the Koreans were very sharp. Like in the electrical vehicles, they have overtaken the Japanese and the Chinese. And so likewise in the robotics. And
Inshallah, Dr. Luqman, one day Pakistan will be also leading the in this
yeah,
field.
surely, sir. Surely,
I am
sir.
looking the I am looking the Muslim countries, even Iran. If you come
Yeah,
here
Iran,
and
sir,
see,
absolutely, sir.
Iran is one of the best country, topper country in using the stem
Absolutely,
cell
sir.
technology.
Original research.
Yes, yes, original research there.
Original
Okay,
research.
thank you, Dr. Salma Kundi, over to you to conclude it because we are.
Okay, thank you,
you.
Professor Malazam Saab. It was a great talk by Professor Luqman Usman. We are really, really grateful to you, Professor Saab, for taking out the time and so early in the morning because I'm sure it is 6 a.m. for you when you started. And I thank all the audience and my special thanks to Professor Malazam Saab, who's proceeding today to Iran. And probably he'll come back with some other topics on artificial intelligence from there
Yeah.
and bring in
Please pray
some
for us
speakers.
also. All the prayers.
Yeah, please do pray for all of
Thank
us.
you.
And
Thank you
Dr.
so much.
Luqman, it was great having you here. Whenever you come to Pakistan, please get in touch with us and do guide us on how to proceed because probably the government will not work here, but
Yes.
we in the private sector would like to take the initiative. Allah bless you for your talk and Allah bless
Bless
all of you for
Pakistan.
being present here
Bless
today.
Pakistan.
Have a great
Yeah.
weekend.
Thank you.
Okay.
And
even
I
Dr.
thank you on behalf of PMA, Women Medical College, Azad Jammu Kashmir Medical College, the Pathological Association of Pakistan, Pakistan Physiological Society, and the South Asian Society of Physiology. Allah bless all of you. Allah Hafiz.
Thank you. Thank you very much. Thank you very much. Thank you, sir.
Thank you, Dr. Ayub, for your comments. Professor Ayub, thank you. Inshallah, we see you after 10 days. Okay, thank you so much.
Inshallah, we'll see you. Thank you.
Okay, sir.